Very good evening to all viewers in India and those who are abroad. A good afternoon. Today we have a faculty talk on hematuria, and this will be given by Dr.Nikhil Vasdev. So before we start our webinar, we will just offer a small prayer to Ma Saraswati.
Saraswati Namah. Tubhyam Varde Kamarupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada.
Thank you. So we start by introducing our faculty today. Dr. Nikhil Vasdev is a consultant urologist at Hertfordshire and Bedfordshire Urological Cancer Centre, Leicester Hospital, United Kingdom. He has a special interest in uro-oncology and robotic surgery. I haven't given the full introduction in the form of the innumerable publications that he has, the multiple awards, and the innumerable workshops that he is doing throughout the world. So welcome, Dr. Nikhil Vasdev, to our teaching session. Thank you very much for sparing your valuable time here. And today we have two special invitees with us, Dr. Ajit Saxena, again a very popular urologist in our country, and a very good friend and an elder brother to me. He is a consultant urologist at Indraprastha Apollo Hospital, New Delhi. Welcome, sir, to this teaching session. And another special invitee today, we have again somebody from Singapore, Professor Ho Yi Tiong. He is a consultant urologist at National University Hospital, Singapore. Thank you, sir, for joining us and sparing your valuable time. So now I would request Dr. Nikhil Vasdev to share his presentation and his deliberation on hematuria.
Well, thank you very much for the very kind introduction, Professor Priyadarshini, and it's very nice to have Dr. Saxena and Professor Tiong joining us, and obviously the entire faculty at your prestigious organization. So I've been tasked to talk to you about bladder cancer, but what I've done is, in the context of a resident-based teaching, have included some important data on hematuria about what we do in the UK, why we do it, which also forms a lot of the international guidelines which come through. So my center is the Leicester Hospital in Stevenage, which is just located north of London. We have a high volume urology practice with a catchment of approximately 2.9 million patients who come to us. And we have few hospitals, including the Mount Vernon Cancer Center, which comes in under our trust. We have 4 robotic surgeons. We have 2 robotic systems and imminently 3 robotic systems, but we do about 350 to 400 robotic urological cases per year. And with bladder cancer, I do robotic cystectomy and robotic intracorporeal reconstructions. We have 2 Royal College of England fellows who train with us too. Now, during the COVID-19 pandemic, which is amongst us all in different ways and forms worldwide, we have seen a drop in the number of cancer referrals being sent across, especially last year. But with bladder cancer, we haven't really seen this take place, because if a patient sees blood in the urine, they will come forward and seek help. Whereas with prostate cancer, especially when it's early, it doesn't come forward. So with bladder cancer, we saw a decline by 20%, whereas with prostate cancer last year, it was down by 80%. But now things seem to be improving and stabilizing. And being on the national response team for the COVID-19 response for the country, the message is loud and clear in the papers that we put out, that come forward if patients have symptoms, because we're here to help them. Now, what I've done is, for the purpose of this talk, I'm going to talk to you about hematuria, bladder cancer diagnosis, some treatment options, and something new on cystectomy. So I published this book 4 years ago with Greg Vasdev, who was my chief trainer, who's now in South Africa. And Professor Ho Yi Thong also contributed to this book with a chapter on hematuria and transplant patients. But hematuria is common. Adult population can be 5%, and patients over the age of 50, 10% of them can have non-visible hematuria. And even in the pediatric population, this cohort forms about 1% of patients that come across and see us. Now, in the UK, we have set guidance in primary care. So we tend to see patients with hematuria depending on their age and their symptoms. So the primary care practitioners or the general practitioners have been instructed to refer patients into the hospital if patients above the age of 45 who have unexplained visible hematuria with or without a UTI, and visible hematuria that persists or occurs despite treatment with antibiotics for a UTI. So this is on the basis of a paper that I published in urologic oncology as a specialist registrar in Newcastle, which I'll share with you. Also, patients above the age of 60 who have non-visible hematuria. And we also now have fairly clear-cut guidance as to who we need to refer on to the nephrologist who might have a negative urological investigation. And non-urgent referrals for bladder cancer in people above the age of 60 who have persistent recurrent UTIs, because persistent recurrent UTIs can be a symptom of bladder cancer too. So the referrals which come across, so we have certain targets that we have to work on in the UK. So if a patient comes across within 14 days, they have to have a diagnosis established. And within 31 days, they have to have their primary treatment done. So this is how different hospitals are gauged at. There are very, very strict guidelines that we have to treat patients in a timely manner, which I'm sure is applicable worldwide, internationally, to ensure that all patients have their CTs, MRIs, flexible cystoscopies, and TURBTs fairly quickly to prevent any delay in the diagnosis coming through. So it's important when you have a patient with hematuria to focus on a few points in history, whether there are histories of stones, malignancy, UTIs, previous histories of cardiac issues if patients are on anti-clotting. Lots of patients are on anticoagulants right now. Past medical history of abdominal surgery, pelvic radiotherapy, if a patient's been a smoker, occupational history. So in the UK, we tend to see this in patients who've been working with rubber dyes, patients who've been exposed to hair dyes, some hairdressers in the past, in the 70s. So this is just a broad spectrum history that you want to take. And in India, of course, you want to take a history of tuberculosis too, and also foreign travel for bilharzia and schistosomiasis, especially in the Middle East and that, in and around that belt. So factors that predispose patients to develop bladder cancer can be cigarette smoking, and this is higher in slow hepatic acetylators, industrial carcinogenesis such as aniline dyes or alpha-naphthalenes, phenacetin, cyclophosphamide, but also there's been some genetic typing taking place to look at the karyotype changes which could be associated, especially with, there's a family history. So chromosome 9, chromosome 17, chromosome 13 with retinoblastomas. And a lot of the immunotherapy models being developed with newer drugs coming through to do with the HRAS and overexpression mutations of FGF, VGS, and overexpression. So, there is a strong genetic karyotypic link, especially taking place in the context of non-muscle invasive bladder cancer. So when a patient comes and sees us in the clinic, we'll obviously take a history, examine them, and we do a one-stop service. So patients will have an ultrasound scan or a CT urogram and a flexible cystoscopy in the clinic itself. And we will obviously perform a general examination, examine their abdomen, examine their prostate with consent. But we also want to make sure that patients don't have pre-malignant conditions on cystoscopy, such as, and this is obviously biopsy proven, and we have facilities to do biopsies in the clinic, which includes keratinizing squamous metaplasia, urothelial dysplasia, cystitis glandularis, which can cause adenocarcinoma. Leukoplakia here has a weak association, but myeloplakia here has a slightly higher association. In the hematuria clinic, we will also perform dipstick tests. Cytology is something which was very popular, but because of the sensitivity being low, is not as popular as to what it is. We evaluate the EGFR because this forms the basis of referring patients on to nephrology in the event of a negative urological investigation backup taking place with a normal flexible cystoscopy or imaging. For patients who have gross visible hematuria, we will do a CT scan of urinary tract with contrast. That's a triple phase scan. or else if patients have non-visible hematuria, as per our guidance, we will do an ultrasound scan and a plain X-ray KUB. And obviously in our clinics, we have to have a nurse present when we examine anybody, which is standard policy in the UK. Now, it's important that the dipstick analysis that is done properly, because you can have some false positives too with myoglobinuria, oxidizing agents, and peroxidase. So if someone's run the London Marathon and they do a dipstick test the next day, they're likely to have non-visible hematuria. So we tend to take a proper history before. And you can also have some false negatives when there's a high level of ascorbic acid, nitrites, or a previous UTI, or there's a high specific gravity of the urine. But this is obviously hard to pick up in the context of doing a dipstick test in the clinic per se. Now, cytology specimens have to be collected very accurately. There should be a mid-morning voided sample. The sensitivity can be as high for high-grade tumors being 84% and low-grade tumors being 16%. But with carcinoma in situ, based on the data presented and reported, it's very variable. The sensitivity can be between 30% to 100%. So overall, the specificity is high, but the sensitivity is low. And hence the reason why cytology, despite it being a very cheap test, may not be as popular due to the low sensitivity. So not a great test, but for follow-up, it has a role to play. Now, something which my group very closely works on, and we published recently in Nature and Urologic Oncology, and I'm happy to share these papers with Professor Priyadarshini to share with your team, is to evaluate as to how biomarkers can be used to enhance diagnosis. And this schematic just tells you the different type of biomarkers being developed. My specialist interest in my lab is to do with keratin exfoliated cell markers and with extracellular vesicles, which is microfluidics for bladder cancer. But there's a strong role to play not only in diagnosis of bladder cancer, but also in follow-up. So right now we have a project which is ongoing in which we have a big backlog of patients who are waiting follow-up cystoscopy for bladder cancer. And we are doing active biomarkers on this cohort of patients to prioritize those people who have positive biomarker tests to come forward for a cystoscopy. Because as of this morning, we have about 1,900 people waiting for follow-up cystoscopies in my center itself, which is a larger number in the country. And this is a slightly busy slide, but kind of summates what the different sensitivity specificities of the type of biomarkers are. But you can see this can also vary. You have very strong enhanced biomarkers, such as the MDX Assure test, 97%. But what I've been working with, which has just got covered in the national press, is a Euro 17 cytokeratin biomarker. So this is a paper that my marker was covered on the Daily Mail about 4 weeks ago, because the sensitivity of a keratin biomarker is 100%. So if there's tumor, we pick it up. And that's something which we are working on, which we have developed locally, both here and in the United States. So the question comes up that bladder cancer, yes, it's not as common as prostate. It's probably the 8th commonest malignancy in the UK and in Europe. I'm sure it's similar worldwide. Is there a role to offer a screening program? The evidence certainly doesn't suggest that. So this was a paper from Brighton et al. Published in the BJUI, in which they looked at about 2,356 patients, but there were very, very low number of patients picked up. But this was on a screened population with a flexible cystoscopy and cytology. But what we are trying to do is probably think about screening high-risk populations, such as firefighters, people who've been exposed to chemicals, and that's a project that we have underway from the NICE guidelines point of view. The protocols that we have in the UK for using a CT scan of urinary tract for gross visible hematuria versus an ultrasound and a KUB for non-visible hematuria largely stems from 2 large papers. So these are publications from Kandra et al. In Newcastle, where I trained. So this is J.U. Roll in 2000, in which the cause of hematuria. So if someone has gross visible hematuria, the chance of finding a bladder tumor is about 20%. Whereas if someone has non-visible hematuria, the chance is 2%. And also these papers reinforce the need to do a contrast phase imaging of the upper tract to make sure that an upper tract lesion is not missed. So this forms the basis of what we tend to do. Now, we've also looked in detail to see whether the introduction of fast track referrals in the UK have changed the T stage of tumors coming forward, i.e., do we tend to pick up more tumors when patients come and see us quicker? The answer is absolutely it does. So this is just a comparison on a paper that I published in 2012. in which we've compared the T stage of patients before and after the introduction of the 2-week rule. And certainly, we have picked up more and more early tumors, which is expected, reinforcing the rule and pathway pressure that we're under. And also, a very common question comes up is that if someone has hematuria, do they have bladder cancer? Is the hematuria always attributable to a UTI? And the answer is that, if someone has persistent UTIs and the infections don't clear, don't ignore them. Because in the cohort of patients that we evaluated who had positive and negative MSUs, that if someone has persistent UTIs or their hematuria persists despite the treatment of a UTI, they should come forward to be investigated. And this is data from about 1,800 patients. So this again forms the importance of investigating patients with hematuria, be it visible or non-visible, with a UTI. Now, in the UK, we came up with some up-to-date guidelines in 2018 in collaboration from the Renal Association and from BAUS, in which we looked and see as to which cohort of patients need to be referred in to the nephrologist to be seen, because you do have certain individuals who do require evaluation, and essentially it's down to the GFR, if they have CKD stage 4 or 5 disease, if they have proteinuria, they have isolated hematuria with hypertension above the age of 40, or visible hematuria coinciding with an intercurrent infection. So we tend to send these patients to a nephrologist who may do some more tests and might also consider a kidney biopsy. Now, suppose you pick up bladder cancer on a cystoscopy. What we tend to do is we do a map. This is what we tend to have in the outpatient clinic to tell us exactly where the tumor is located. And we can then we give patients information on the details of a TURBT covering the common, occasional, and rare side effects. Patients are dated for theater, and the aim is to obviously perform a complete resection if you can. So this is something called an en-bloc resection that I tend to do with a Collins knife if at all possible. But if you have to do a piecemeal resection, you want to use a resectoscope and get all the pieces out. But something new which is on the horizon in my center is the thulium laser, which is being led by one of my colleagues called Christine Gann, who in patients who are not very fit to have an anesthetic, this is easily done with a flexible cystoscopy guidance. And it's easy to laser ablate these smaller tumors. And it does really have a very high success rate in dealing with superficial bladder cancer, especially in patients who may not be fit to have radical treatment. Now, as far as the TURBT is concerned, I think there are certain principles which are very important to take place, because in most tumors, 70% of tumors, if it's done correctly, you can actually remove the whole thing en bloc and cure it. And it's crucial that a TURBT really helps you stratify. So you want to make sure your quality of your TURBT is very, very good, to make sure you have muscle, to ensure that you have features which your pathologist can identify, such as lymphovascular invasion, because the worst thing to do is resect at such a high current that the entire tissue is totally charred, making it not interpretable for the pathologist to comment on the T stage, and a re-resection is required. And, in high volume centers, sometimes trainee urologists do the operation, but it's important, something which we reinforce up here, is all TURBT, especially in the beginning of someone's learning curve, are supervised properly, because the fear of a perforation is so high sometimes that you may not do a complete resection. So we have consultant supervised lists where our trainees do come and train on. The operating procedure of a TURBT, of course, is to ensure that you have detrusor muscle present. You also want to use either monopolar or bipolar resection. And this is just a demonstration of how we are using a holmium laser to ablate and lift a TURBT out. You can see the bleeding risk is lower. But in resection of small tumors, it's better to ablate the whole tumor if at all possible, and certainly give them an intravesical washing post-operatively. So this is a paper which was published 2 years ago on what techniques you can use to prevent an operator kick. You can have this under spinal or a general anesthetic, the use of a muscle relaxant, preventing overfilling, using lower cutting and coagulation settings, and short bursts certainly seems to be the way forward with TURBTs to reduce the operator kick. Now, once a TURBT has been done, you will get information such as TNM staging, and that's the 2017 staging we use. So obviously pathology-wise, you have a cutoff, whether it's T2 or T1 or TIS or TA, but obviously your imaging, your CT scan, and your MRI. So what we tend to do is, in anybody who has got evidence of muscle invasive disease on a flexible cystoscopy, we will do a MRI before their TURBT, because these scans are so sensitive that post-operatively, due to the extravasation of the irrigation, etc., they can overcall T3 disease. And it's also important to evaluate the lymph node status. On Sunday, I gave a talk at the North Zone USI meeting talking about lymph node dissections during cystectomy, but it's important to evaluate lymph node status preoperatively. And I think up here is a very strong role of FDG PETs in due course, which can predict where the lymph nodes are located and what they're functioning at. So I think FDG PETs will probably form the state of play in the future with bladder cancer, especially muscle-invasive bladder cancer. Now, on 2 Mondays a month, I do something called a blue light list at my center, in which the PTD fluorescence cystoscopy certainly has been shown to show a higher sensitivity to pick up carcinoma in situ. So this is given, the drug, the Hexvix, is given about 60 minutes before the TURBT. We have a full group of trained nurses who facilitate the entire process. And it's an expensive technique, but I think it's very, very useful if you suspect CIS. And I use this for re-resections in certain patients too. So you can see that, in certain patients in which you suspect CIS or carcinoma in situ, you can really have a lot of confidence to pick up these tumors per se in the context of carcinoma in situ. And this forms the basis of confirming, ensuring that the treatment that we give to patients such as BCG, etc., in due course is something we want to discuss. I'll just give it a few minutes because the presentation seems to have just stalled a little bit. But covering the evidence which exists right now for PDD, it's good to pick up carcinoma in situ. It's commissioned in the UK right now, but we just had some data published from a randomized controlled trial in the UK called the PHOTO trial, which was presented at our national meeting last week, in which the evidence is slightly equivocal. So we're waiting for this publication to come through to confirm what the state of play will be with blue light cystoscopy in the future, especially in the NHS. And some meta-analysis on blue light, again, confirming better quality of resections and CIS. Now, we also use narrowband imaging. So you can see narrowband imaging essentially picks up hypervascular tissue. So in smaller lesions, you can pick it up and you don't require any preparation in the bladder preoperatively. You just flick your switch on the cystoscopy and you'll be able to pick up. So that's the difference between white light and NBI. Initial studies have showed improved cancer detection rate, but recurrence data is yet awaited. Now, a lot of patients who may have had an incomplete resection may need to come back for a second resection. So this is, again, one of my papers looking at the residual volume, residual disease on second stage. And I think second resections have a very strong role to play, because you want to make sure that there's no residual tumor pre-radiotherapy. But most importantly, you don't want to undertreat muscle-invasive bladder cancer, because the recurrence-free survival is very different between muscle-invasive and non-muscle-invasive bladder cancer. And when we've looked and seen as to what the upgrade can be, so you can see down here that in T1 disease, it can be as high as 55%. And whereas when you have muscle-invasive bladder cancer, it can be 25%. So if there's any doubt that you might not have got the whole tumor out, or you want to go back again, have a low threshold to do so, because data certainly indicates a strong benefit with pre-resections. Now, in most of our patients, so that's 98% of patients, we tend to give them Mitomycin C on table following TURBT. This is antibiotic chemotherapy. It inhibits DNA synthesis in the G1S phases, and it ablates the tumor at the resection site. We give it at a preparation of 40 milligrams and 40 ml of saline with a catheter clamped. There's certain risk factors which you have to consent patients for before you give them mitomycin. So extravasation, some low urinary tract symptoms, and surprisingly, I've seen this twice in my career, in which they can get severe dermatitis with the palms of their hands. So that's something to consent patients for when you give them mitomycin. Now, the evidence largely stems from Sylvester's papers in JU Rod in 2004, in which the risk reduction of a recurrence is 12%, but the relative risk reduction for recurrence, again, is 39%. So it reconfirms that a single dose of mitomycin reduces the risk of recurrence. So this is the standard of care that we tend to adapt in the UK, and I'm sure it's very similar worldwide. When I worked in Singapore with Professor Thiong, we used to give the same thing up there. And the question is, a course of mitomycin, when do you tend to give it? So the systematic review, again, from Sylvester, published in European Urology in 2016, showed that the difference in the 5-year recurrence-free rate was 59%. So a course of mitomycin C, that's 6 instillations, can help to prevent further recurrences. So once a patient has had their TURBT performed, we tend to discuss all their cases at our special MDT meeting, because we want to look to ensure that there's no carcinoma in situ, there's no lymphovascular invasion, to also evaluate patients with muscle invasion and clinical trials. We have a lot of adjuvant immunotherapy, neoadjuvant trials that we are running and adjuvant trials that we're running for muscle invasive bladder cancer. And it's also important to risk stratify and prognosticate these patients. And that's largely based on the NICE guidance, in which we stratify patients into low risk, intermediate risk, and high risk based on the T stage, the size of the tumor, and the focality. So if it's multi-resistant, solitary, or especially if a tumor comes back after chemotherapy, intravesical chemotherapy, they go from low risk to high risk. So that's what we tend to grade our patients with. We also use the EORTC tool, which is fairly similar to NICE, to stratify patients into low risk, intermediate risk, and high risk. And you can see down here that this is the calculations that we tend to put in based on the number of tumors and the scores that we tend to get from the EORTC calculator, which is available online. And this particular graph just indicates the difference in how tumors behave with first recurrence, with the cumulative index, and most importantly, progression. So high-risk tumors, if they're not treated appropriately, will progress. So that's important to consider in the context of dealing with patients with bladder cancer. So if you look at the prognostication data from the EORTC, comparing both your recurrence scores and your progression scores, you can see that the percentage, depending on the score deciphered, both at 1 year and 5 years, once again highlights that the higher the grade of the tumor, there's a higher chance of cancer coming back. A lot of controversy lies with T1G3 disease, and this is what we tend to see fairly common now, especially when patients are referred in to our center, which is the tertiary center, and we resect them, is that it has gene alterations similar to T2 disease. So it should be equated to be a fairly aggressive tumor. And the recurrence rates can be as high as 70%, but most importantly, the risk of progression is about 25 to 50%. So this tumor group has to be watched very, very carefully. So this is a paper from Professor Kesavan S. Varanathan, who I work with at the National University of Singapore, doing some research on bladder cancer. But this schematic just highlights how BCG works. BCG has been a popular drug from 1976 from Moral's group. And again, it works towards the stimulation of Th1 lymphocytes, which cause a cytokine surge in the bladder. It is a live attenuated vaccine. We tend to give it within 2 weeks after TURBT. The schedule is a 6-weekly schedule, and there's no reason why there's a 6-weekly schedule. It's essentially down to the fact that the batches of BCG, which used to come in a batch of 6. So that's how it was rolled out. But the aim of BCG is to prevent progression. It's not to prevent recurrence to such a degree, but to prevent progression. And hence the reason why when my resident comes and tells me that this patient needs a cystectomy because his CIS has come back, I always tell them that, look, if it hasn't gone into the muscle, we have to be a little bit cautious to call it a BCG failure. And I'll share some definitions with you shortly. So looking at BCG, what is the evidence? Again, Sylvester's paper in JU Rod in 2002 highlighted that the reduction in progression was 4%, but the relative risk reduction in progression was 27%. So that reaffirms how BCG works. And this is a meta-analysis on 24 randomized controlled trials. So again, the latest evidence which comes out of BCG suggests that you can have a large number of patients, but if you look at more evidence, it's about a 32% reduction. So that 25 to 30% percentage is what we tend to go with. We have 2 nurses in our department who give BCG, but they always give advice to patients such as, don't drink for 4 hours after instillation. Remember, to take aspirin and anticoagulants. And there's some early evidence to show that patients who are on aspirin have a better response, whereas patients who are on warfarin have a lower response. So we're not sure why this is happening, but we suspect this might be related to some cytokine surge, which is being prevented in the bladder, such as interleukin-6 response rate. So we have a trial right now, which is just closed, called the BOXIT trial in the UK, in which I was involved, in which we randomized patients to aspirin with BCG versus BCG alone. So that data will come through next year. We also want to ensure that patients, when they do void post BCG, put a bit of bleach down into the toilet because it is a live attenuated vaccine. Now, BCG comes with side effects, so it's important to tell patients that serious side effects can happen in less than 5% of patients, but side effects normally could also stop once the treatment is stopped. So you have to draw a balance between what you like to achieve with BCG treatment. The toxicity profile of BCG can be mild, such as cystitis, to as severe as sepsis, and also allergic reactions taking place. And if you do suspect that someone is getting tuberculosis, do a urine for AFP, early morning samples ×3, and start them off and refer them to the respiratory team, which we tend to do to start off anti-tubercular treatment. Now, these are very important definitions because BCG failure, BCG resistance, BCG intolerant, BCG refractory essentially are different terminologies which are being used, because relapsing means that the tumor is coming back within 6 months. Intolerant is the patient can't tolerate it. Refractory is when failure to achieve disease-free survival at 6 months. And resistance is basically when the tumor is not budging at all and still persisting. So this is the cohort of patients we manage when we give them BCG. So it's not an all or none phenomena. With BCG, it's much more broader than that. And if someone fails BCG, we have certain options available. Obviously, cystectomy is an option. But right now, we are talking about immunotherapy. So I've just finished, I'm sort of CI for something called the THOR-2 study up here. We're the first center in the UK. We just finished recruiting 4 patients in which we are giving standard of care with oral FGFR3 immunotherapy agents based on tumor molecular profiling. So not only are we looking at the T stage when we do the biopsy, we are also looking at mutations within the biopsy itself to streamline and individualize treatment. And I think this is where the future will lie in due course. So it's not only going to be a cystectomy, there'll be a lot coming forward with intracycle immunotherapy plus oral immunotherapy for BCG refractory disease. Just touching upon some immunotherapy. So this is a paper of mine published 2 years ago in Reviews in Urology, which was circulated at the AUA, in which we've just summated, what the newer immunotherapy agents are. There's not so much PD-L1 monoclonal antibody work taking place with superficial bladder cancer, but with muscle-invasive bladder cancer, there is a lot taking place with atezolizumab and pembrolizumab for muscle-invasive bladder cancer. So this is probably in the context of patients who will not be eligible for cisplatin-based chemotherapy. But coming back to superficial bladder cancer, carcinoma in situ can be primary or secondary. The PDD cystoscopy has a higher false positive rate post BCG, but CIS has very high mutations of P53. But most of the time we can manage it with BCG, but we also have alternatives in our center, such as electromotive mitomycin and hyperthermic mitomycin, the data of which is obviously awaited. These are new treatments. So 5-year data on recurrence-free survival is awaited for these. So when do we give, does carcinoma in situ have an impact? I published this paper with Peter Black, in which we looked at patients who had neoadjuvant chemotherapy. The answer is we don't really think it does. It's a primary modality. Yes, it's an independent risk factor, but it has response rates similar to what other type of tumors would have, because CIS was thought to be a little bit of a isolated tumor, which is very aggressive. But the truth of the matter is that both at the molecular level and also the treatment level, we tend to have similar adaptability for both type of bladder cancers. Now, muscle-invasive bladder cancer is a different conversation altogether. And we are now using a lot of MRI scans pre-TURBT. And we are similar to PIRADS in prostate cancer. We are using the VIRADS score based on DWI imaging on MRIs pre-TURBT, because the sensitivity of an MRI to predict T2, T3 disease is thought to be slightly higher. But obviously, all our patients will have a CT scan of chest, abdomen / pelvis, with a view to even consider them for an FDG PET if they have lymph nodes present prior to neoadjuvant chemotherapy. The use of PDD so that's either white light or blue light cystoscopy can help pick up CIS when you're doing your resections. And MRI can predict T2 invasion up to 73% of the time. But the criteria right now for lymph node staging for muscle-invasive bladder cancer carries on being 8 millimeters for a pelvic lymph node versus 10 millimeters for an abdominal lymph node. But we have seen, based on sentinel data, that the size of a node is important, but even small nodes may have activity, which may be the reason why we still have a survival rate of 75% in 5 years for bladder cancer in the muscle-invasive context, which certainly needs to improve over time. Hence the reason why I spoke about the FDG PET. So when someone is diagnosed with muscle-invasive bladder cancer at our center, we obviously discuss their case at the MDT. We evaluate their fitness, cardiac, respiratory, EGFR. We discuss neoadjuvant chemotherapy and trials. And we also evaluate their manual dexterity to perform ISC with neobladders. I do intracorporeal robotic neobladders with an ISC rate of 2%, but different types of urinary diversions could have a slightly higher ISC rate. So if you broadly divide radiotherapy versus cystectomy, obviously with radiotherapy, the benefits are you avoid major surgery. With cystectomy, the advantage is you get rid of the tumor, it provides better staging, you remove the lymph nodes, and it's basically instantaneous symptomatic cure. The risk of radiotherapy in the long term are patients may end up with a small bladder, they might be tired, and secondary malignancy is very important to consider, such as in the rectum or in the pelvis, and some patients also develop proctitis. In cystectomy, this is major complication rate, 20%, morbidity 1% at 30 days is what we quote. Obviously, in the robotic context, the complication rates have dropped, and that's a review available online with Professor Kinjavar from Thailand that we published in TUA, looking at the types of different types of cystectomy. Now, neoadjuvant chemotherapy is given. So in my center, it's 45% of patients will have neoadjuvant chemotherapy. The Cochrane review with the latest benefit, again, reaffirms a 5% survival benefit. We tend to give gemcitabine and cisplatin. We also give MVC, but MVC is given in an accelerated regimen. But patients who are not eligible for gemcitabine or cisplatin or MVC now tend to have neoadjuvant immunotherapy with pembrolizumab or acetolizumab, depending on their PD-L1 status. Cystectomy, the state of play is ileal conduit. So 80% of our patients will still have ileal conduit. So we go through all the risks with them. And these slides will obviously be with you to have a read off. But from the anatomical standpoint, the diversions can be ureterocutastomy, ileal, or a colonic conduit. But you can also do orthotopic neobladders. I certainly don't do any rectosigmoid diversions, but you can do a ureterorectostomy in certain situations. But in the UK, we don't tend to do them. So my sort of specialist interest is a lot to do with, so this is my open neobladder, which I was probably doing up to 5 years ago. I don't do any open cystectomy at all now. My entire program is robotic unless I really need to do some in a T4. And we had an IROC trial in which we were randomizing open versus robotic intracorporeal cystectomies. That was the only time I did them. But this is a day 10 cystectomy of mine. You can see a neobladder patient that there's a less risk of a big scar and there's a risk of lower pain. And the metabolic consequences of diversion. So this is a paper of mine in the Indian Journal of Urology in which we have summated what type of metabolic complications patients can get. But essentially it's to do with metabolic acidosis. So this is a common exam question which is asked, and the treatment is largely to do with sodium bicarbonate. The type of metabolic complications depends on the type of segment, gut segment that's being used, whether it's the stomach, jejunum, ileum, or colon, and also your side effects of the patients can be as high as muscle weakness to seizures. But the commonest side effects we tend to see is anorexia, a bit of weakness, and fatigue. So it's important to keep their calorie intake on board. It's important to remember that the mechanism of your hypochloremic metabolic acidosis largely happens because of ammonia absorption. So if you have a patient who comes in fairly unwell after a diversion, you should check an ammonia level to get it under control because it's easy to reverse with hyperhydration and antibiotics. So just, I'll be closing up in 5 minutes, Professor Priyadarshini, but this is the largest series of cystectomies we've just published in the BJUI in the UK, 12,600 cystectomies. And what we have found is that robotic cystectomy is on the rise. Complications and length of stay of robotic cystectomy are dropping, hence the reason why robotic cystectomy is commissioned and allowed to take place. Again, some more papers, Cochrane reviews reaffirming that robotic cystectomy has advantages with lesser blood loss, lesser length of stay. Patients go home quicker, but the main complications, be it robotic or open, continue to be UTIs and ileus. And that's what moves me on to some data that I want to share with you today. So this is a trial up here at my center in which we are randomizing patients who are having cystectomy and intracorporeal conduits to low pressure versus high pressure. And you can see at lower pressure, patients tend to do better. The ileus rates are lower and they're going home quicker too. So there's a big role of lower pressure cystectomy. And that's it. So it's a bit of a whirlwind presentation on bladder cancer, but thank you for the opportunity, and I hope to go on to the discussion now.
Thank you, Dr. Nikhil. It was a wonderful presentation, very elaborate, and I think it was really good, and the residents must have benefited a lot from your presentation. And before we begin our question answer session, I would request our invitees, Professor Thiong and Dr. Ajit Saxena, to give their comments, and then we will begin our session of question answer. Yes. So Dr. Ajit and Dr. Thiong, yes, go ahead.
Yeah, hi, good evening. I'm very happy to be here. Professor Vasdev, that was a very thorough and run through of the entire spectrum of bladder cancer, beginning from hematuria. So, I think you've done a lot of great work, and your research and publication spans through the entire spectrum. That's fantastic to see. Should I start with some questions, or shall we do that after later? Sorry, you're muted, Dr.
Yeah, if you have any query to Dr. Nikhil, just please go ahead. Otherwise, we would request Dr. Ajit Saxena to give his comments, and then we'll start.
Yeah, I think we will let Professor Ajit to yes, say something, and then we can throw
Saxena, it. Please.
Thank you very much. But my video has been stopped by the technical committee.
Okay. Anyway, you can go ahead with your.
I'll just go ahead and speak. Well, Professor Vasdev, my heartiest congratulations to you on doing a very good job. It is a very difficult job to compress everything that you know and that we would like to hear in 40 minutes or so. But you did it very well. Full marks to you on that. And I can see you've got a lot of experience in the CA bladder and Haematuria. For the benefit of our postgraduates, we still tend to do urine cytology as part of the routine regime here in India. Every place you find urine cytology written. Do you think that should be condemned now and that should be in the archives now? And what do you think of NMP 22?
So thank you very much, Professor Saxena. I think cytology is probably a good test in the context of follow-up for patients, because what we found was that the cost of a cytology in the UK is about £60. It's a cheap test, but it's not that cheap either. And the problem is that we're trying to establish sensitivity of bladder cancer with a test, and a sensitivity between 30 and 50%, in my opinion, and certainly the opinion of NICE, which is our regulatory body in the UK, didn't feel it was good enough. So we have actually scrapped cytology from most of our pathways, but in certain patients we might do one. But I feel that biomarkers will probably come in because of the sensitivity and specificity profile of biomarkers will come in and take over cytology. So that's my comment on cytology. Your second question about NMB22, I think it's a good marker. It's a well-established marker. Again, the variability of sensitivity specificity varies from reports from 60% to 95%. But what we require is a strong biomarker. There are a lot of contenders. This market is getting a little bit saturated, but probably it's time now to focus as to how a biomarker will come into interplay with the TURBT, or how we can use biomarkers to help us clear the COVID backlog. So I think NMP22 is a good marker if you use it, but we have a lot of stronger contenders making their way through. Thank you very much.
Great, thank you very much. One other point that I'd like to bring out is about unexplained hematuria. Now we see a lot of those unexplained hematuria, and in my career I used to get really worried about it because I couldn't find a diagnosis and what to do with such persons. Now with 40 years of experience behind me, I can look back and say, this is what I should have done. And I've got at least 3 cases where we started with microscopic hematuria. 2 years down the line, the patient had frank hematuria. But again, we evaluated, nothing found. Then he come out 2.5 years later with clots as well. And again, we would look around and find nothing. But then after that, in India, people get lost till they have dangerous element, and the danger being blood. So this chap returned 3 years later, and this time we found a sessile growth in the posterolateral wall of the bladder. So this is the history of bladder developing. I don't know if you would agree with me on that. And now, in hindsight, I should have followed all cases of microscopic hematuria, given the fact that they tend to disappear.
I totally agree, sir. I think, we have a bunch of cohort of patients who probably our current imaging quality or our cystoscopy will not pick up. Like you rightly said, they may come back again and again. The only good part is that if someone has hematuria, they will come and see you because it's such a panic-driven symptom. They will come and seek help.
Exactly.
And hence the reason why, our push right now is very much in lines with using a potential biomarker with a blue light or a PDD cystoscopy or narrowband imaging to enhance, because it's a bit of a production line, these clinics. People come in, we do a quick cystoscopy, which most of us who are experienced can literally do in 5 minutes. Our CT urogram used 3 millimeter slices instead of 1 millimeter or 2 millimeter slices. So I think if something's in the urinary tract and the urine can pick up a tumor, these patients may benefit. We do have certain cohort of patients who have loin pain hematuria symptoms who might need an auto transplant or more workup, but this is a rare situation to be in. But I agree that your patients that you described who evolved into bladder cancer, probably the initial investigations 40 years ago were not as good to pick up smaller lesions, which obviously in your patient's case did manifest and the patient did have treatment. But some patients maybe, with non-visible hematuria who have a urological malignancy, they never come back and they come with an advanced disease later. So we have to work to see how we can prevent that from happening.
So how often would you recommend repeating the workup of a CT urogram and a cystoscopy for a patient with asymptomatic microscopic hematuria?
So, Professor Dong, what we tend to do is once the urologist has evaluate these patients, we tend to send them to the renal physicians. Now, if the renal physicians find nothing, the standard statement that we say is that 5% of adults will have hematuria, and that is it. So we don't tend to monitor them per se unless they fall into a high-risk group. So suppose they're heavy smokers, they've been exposed to chemicals, we suspect they might have a subtle bladder cancer. So I think it's more to do with risk profile evaluation. We don't have current guidance right now as to how often we need to follow them up, but I think this is more to do with individualized risk profile of patients who might need to come back. I'm not sure what you do in Singapore, but I hope it's fairly similar.
Yeah, I also tend to agree with the risk stratification after you've cleared them completely versus the AUA guidelines that recommend, routine microscopic analysis for the next 3 years, leaving patients anxious, and maybe redundant excessive radiation from CT scans. But probably smokers, family history, occupational exposure, then perhaps these patients may be worth following up more closely.
All right. So of unexplained hematuria, yes, many of these patients, particularly children and young patients, they do come with this microscopic hematuria. And when you take the history, they are used to some exercises, strenuous exercise. And when you ask them to avoid such type of exercise, it usually goes off. And then there are many other causes of unexplained hematuria, as they have explained, nutcracker syndrome and certain cases of AV fistula or aneurysms, and all those may be causing this unexplained hematuria in many of these patients, particularly those who are younger patients. Probably then we need to monitor these patients. If they are older patients, and as you said, of the high-risk group, definitely we should go ahead and investigate the microscopic hematuria also. I think that we have Dr. S.K. Pal with us. So Dr. S.K. Pal, please, you are most welcome. He is a very popular and renowned urologist of our country. So, and a very good and a very PCNL expert. So Dr. S.K. Pal, any comments from your side?
Good evening, Shivam, and good evening, Nikhil and all. Excellent, very exhaustive presentation, Nikhil. It was really good. I enjoyed. Just wanted you to make 2 points clear regarding BCG installation that is very commonly being done in our country with all the CA bladders. So in 2015, there were few papers which said that there is no difference between 5 doses versus 6 doses weekly intervals, and 120 milligram versus 80 milligram. So to reduce the toxicity and side effects, what we have been doing since last 7-8 years is only 5 doses of 80 milligram BCG every time. What are your comments on that? Whether we have reverted back to 6 doses or this is the ideal regime?
Thank you very much, Dr. Pal, and nice to see you, and thank you for your comments. You know, I think if we go back to 1976 as to why we were giving 6, it was the batch production of the BCG being in batches of 6. I'm sure if there were batches of 5, they would have 5. If there were batches of 4, they would have 4. So based on recurrence-free survival data, even some centers have given 27 milligrams of BCG to reduce the dose even more. I think the cytokine response, the Th1 response, will probably be the same between 3 doses and 6 doses. So if you are giving a lower dose and having better patient outcomes, because the worst situation is for patients to start BCG and then stop, then you're really not in a position to cure them. So I think this is individualized based treatment. And, you know, obviously, if it's working well for you, I would not recommend you change it. Even we tend to drop the dose down to 80 milligrams if a patient can't tolerate it, and even sometimes 27 milligrams. So I think this is individual based. There's not much evidence out there because I think people are skeptical to challenge giants like LAMP from 6 installations to 4 or 5 or 6. But I think it's perfectly reasonable, and if patients are being monitored and their cancers are not coming back, it's obviously working well.
Secondly, what is the regime for the booster doses, maybe for maintenance therapy? Is there any accepted regime? There are so many regimes and it is very confusing.
So we follow the EAU regimen of maintenance at 3 months, 6 months, and 12 months. So we finish off at 15. We noticed that once we went beyond that, we had a big review in the east of England. What we found was the toxicity in the long term with a small contracted bladder and cystitis was a problem.
Yes.
And oncologically, this was a good way forward with 6 plus another, essentially 9 more installations at 3 months, 6 months, and 12 months. So that's what we tend to follow.
Thank you. Thank you.
Regarding the frequency reduction, what do you think about the Nimbus trial? Recently, apparently they published inferior outcomes when they reduce the frequency to 3 times. You know, there may be some, we can try to reduce the frequency, but perhaps 3 times may be too low.
Yeah, I would agree with you, Professor Thiong. That's why I went, when Dr. Pal's question came, I didn't go to 3, I went to 4 and 5, because the Nimbus trial certainly showed a disadvantage when you went below 3. You're right over there. And thank you for quoting that study.
But the actual thing is, if the person is tolerating the dose, the first dose, second dose, and even the 120 milligram, usually we would not reduce the dose or the number of installations because they would tolerate even 6 installations. So if they do not tolerate even the first or second, then only we think of reducing the dose or reducing the number of installations. I think probably that should be the way forward, because if they are not tolerating, they would not tolerate even 5 installations. So what about, because once 1 or 2 years back, we heard that United States had a deficiency of, there was no BCG there, and they were trying some other intravesical therapy. What about in Europe and other countries? In Singapore, do you have BCG easily available?
Yeah, actually, that's one good question that I was going to ask Professor Vasdev and you all in terms of the strain and the efficacy between the strains. So, I mean, Kunot strain is no longer available. So in Singapore, we are using the Tokyo strain. We do use 1/3 dose, but follow the same 6+3 regimen. Otherwise, there are very few other alternatives, and we are actually awaiting the use of pembrolizumab for all the BCG failures. So I think that is probably what we're looking forward to, the immunotherapy for even non-muscle invasive bladder cancer.
So Dr. Nikhil, what about in your UK and other European countries? BCG available?
So we had sort of alert which came out in 2016, and I still remember, Professor Tiong, who had come for the EAV, we had a chat about this, in which we were told that our manufacturer, who was from Canada, there was an issue with the manufacturing per se, and we were prepared to offer a lot more cystectomy than what we did. But we didn't. We actually got our strain from India. The Indian manufacturer stepped in to buffer the gap, and then we've had a chain from Belgium, which is essentially the Connaught, and even now the Tokyo strain is what we tend to use. I feel that, this is a popular treatment, but like Professor Tiong said, a lot more is to come. So we are talking about intravesical gemcitabine being the standard of care now. We're talking about interferon alpha 2B being developed because that gives the same cytokine response with less toxicity. So in due course, newer treatments, regimens such as hypothermic mitomycin C or mitomycin C. So a lot of new products in the market which will buffer a BCG shortage. But for the moment, we are fine, Professor Priyadharshini, but probably 2016, 2017 was a little bit sketchy, where we thought we might have a drop in production.
All right. So because fortunately in our country, we didn't have any shortage of BCG. Still, we have the two strains available, Moscow strain and the Danish 1331 strain, which is available easily in our country. So there are now, they are trying for other intravesical therapies, like they are combining docetaxel and gemcitabine also. And then many of these centers have procured this HIVAC system for more absorption of these chemotherapeutic intravesical drugs. So are you using this HIVAC system regularly in your place when you give intravesical chemotherapy?
So we use it in BCG refractory disease. We haven't been able to commission it as a primary modality because it's slightly cumbersome once you do a TURBT to get a HIVAC system, and we give mitomycin on table to our patients. But the long-term data on these technologies is still awaited. Manufacturers will say what they want with the in vivo studies which have taken place, but we need to wait for some longer follow-up to come through. But in the UK, there are lots of centers who are doing HIVAC and mitomycin as a part of a trial which is finished. But this will probably be the standard of care with all intravesical drug delivery in the future, is the way I look at it.
Tiong, yeah, in Singapore?
No, we're not using these. We're not using these additional adjuncts.
Okay.
Dr. Nikhil, long time back when I was in the UK, we used to have these haematuria clinics. Are they still prevalent, or what's happened to them?
So they're still there, but it's about a one-stop clinic. So we do a one-stop evaluation for all these patients, which helps because by the end of the clinic, we have an answer for them straight away. And we tend to date them in a week for their BTs if we can.
All right. So what about, do you use a flexible cystoscope and you do it under local anesthesia in the OPD clinic only, or you usually ask the patient to come in the OT and do a rigid cystoscopy for evaluating hematuria?
So we do flexible cystoscopy in the clinics. Most people tolerate it fine. Obviously, if there's somebody who's very squeamish, they want a bit of sedation, then we bring them in. But we don't tend to bring them into theater if we can help it. And this is also down to COVID and the cumbersome tests and coming across, etc., which is required because we all wear the PPE and do flexible cystoscopies. And we really didn't stop even during the first phase of the COVID pandemic. So we have a tolerance of 99% of flexible cystoscopies, and it's fairly instantaneous, and we get the answer straight away.
Right. In Singapore also, Professor Tiong, you do a flexible cystoscopy routinely in these patients?
Yeah, we do flexible cystoscopy. It's quick and well-tolerated outpatient. But my questions actually to you all is also, the difference between PDD as well as versus the narrow band imaging. I think one big difference is the cost. The cost difference using blue light cystoscopy is so significant. So I know, Nikhil, you favor the blue light cystoscopy. No, so what do you think? I mean, does it compare very much the narrowband imaging in detecting CIS or small lesions in your experience?
So just 2 points there, Prasad. One is we have a enhanced tariff to the hospital because there are only about 16 hospitals which do it in the UK. So we get a lot of people referred in. Okay. So every time I do a PDD, the hospital gets an enhanced tariff of about £850. So which is a good thing because it's an enhanced service.
Yes.
I think narrowband imaging is good because you just flick a switch and you will pick up a tumor because it follows the blood vessel lining, so smaller tumors. But I don't think it's that great to pick up carcinoma in situ. Like I'm surprised with PDD sometimes when patients come across, when you switch over to PDD, you pick up these areas which look totally normal and they have tumor sitting within them. So I think, but the question is, how do you suspect someone has CIS? It's not symptom based. I think it's more to do with the risk profile. So if you have we tend to do these in younger patients who have a lot of irritative lower urinary tract symptoms, who have big tumors, patients who need a re-resection. But this is opinion-based. This is not a guideline because this is a fairly new technology, although it's been around for a while. I think what's putting it from running is the cost and the logistics, because I can do 5 white light bladder tumors on a list, but with blue light, because you have to put a catheter, give them the drug, it's 3. So the only way we are able to do this from the cost point of view is because the hospital earns more money when we do blue light from the commissioning group negotiation contract.
So, yeah. So, Dr. Nikhil, does that mean that there is not much of a difference between narrowband imaging and the blue light cystoscopy? Because narrowband imaging is widely available in our center. Also, we have NBI. Just change the thing, and then you can do an NBI also. But at times, but again, there are some false positive results with both blue light and NBI. So the question is, then when would you like to do a random biopsies in these patients to pick up those carcinoma in situ? So you can't depend totally on NBI or a blue light cystoscopy. So what are your indications for doing a random biopsy?
So if you look at the data on blue light false positivity, it's largely to do with post-BCG patients, because there was a big trend to biopsy patients who had BCG to have a blue light check. So the sensitivity of your question is, when will I do a blue light? I would do a blue light when I suspect carcinoma in situ, when there are multiple red patches in the bladder, when a patient requires re-resection, when a patient requires a salvage cystectomy or wants a neobladder under my care, because I want to make sure that there's no carcinoma in situ anywhere. There's a big difference in both the techniques. I am a fan of PDD because I brought it to my center, I trained on it, but it is a very, very specialized procedure. It's not something which should be done all the time. It has to be specialist indicators. And hopefully by the end of the year, we'll have some more guidance as to when this should be done for sure. But NBI essentially is more of an enhanced flexible cystoscopy, because you're not giving an agent in the bladder which is binding to cancer. It is a visual technique which uses a filter to enhance and reduce the red glare in the bladder. So it buffers the red glare in the bladder. It's infrared imaging. Whereas with blue light, you have a genetically tailored dye using a krypton ion bulb, which binds and eliminates invisible tissue to the human eye. So that is the difference. So it's like, when one gets a little bit old and you need reading glasses, that's the way I look at NBI. But when you have to pick up something which is hiding is when you need PDD. So that's the difference of how the two will work.
Yeah, I also agree with Prof.
Yeah. Yes, Professor.
That I also agree with Prof. Vasdev that seems to be more reassuring data from PDD in terms of the data in reducing recurrence. Although the NBI is a 2,000 Singapore dollar difference for the patient, and I also found that sometimes I switch the NBI on when I'm doing the flexible ureteroscopy to diagnose upper tract lesions. But I think the data on PDD is stronger and more reassuring that it actually makes a difference.
All right. In your lecture, you said about your urinary biomarker cytokeratin. Till now, what we have learned from the literature is that most of these biomarkers, be it NMP or be it immunocyte or the FISH test and all those, still they are not up to the standard. Maybe they have not come into the clinical practice because still the sensitivity and specificity is low. Still, we in our country use urine cytology as the follow-up study in most of these patients. So do you think what you're saying, that cytokeratin could be one of these follow-up tests in the coming time?
So I have sort of been involved in the development of this Uro-17 cytokeratin marker. So I believe in it, but it's a product which I've been involved in developing. But I think, you know, biomarkers will have a strong role to play. The reason why I say this, Professor Priyadarshini, is two. One is, if you look at patients who come with hematuria, if someone has gross hematuria, there's a 20% chance of cancer being picked up. But if someone has non-visible hematuria, which is a majority of the patients who come and see us, they go and see their GPs about something, they have a little bit of blood and they come across. We are investigating 98% of these patients who have no tumors. It's a big pressure on a health resource in which you have a catch of 2% of malignancy. Yes, you might pick up stones and so on, but 90% of the time, we don't pick up much pathology at all in these patients. So the question is, do we have a test, which is a non-invasive test, which is like a urinary test, which can help stratify and predict what to do with these patients? Because I think medicine, I hope you all agree, is changing from a, you know, not all size fits everybody. It has to be individualized based care. And I think that's when a biomarker will come in to help stratify this group of patients.
Yes, definitely. We would like to have such a biomarker which will confirm whether the patient has malignancy or not. But till now, it has not been there. We cannot confirm it. And anyway, we have to do a cystoscopy to confirm whether there is a malignancy or not till now.
Nikhil, out of these 98% where you don't get malignancy, we have a very high percentage of patients with tuberculosis. Yeah. I think that is not there in Europe and in UK. I don't know about Singapore. How often do you see microscopic hematuria and the cause being tuberculosis only?
Yeah, not common at all, but it is at the back of our minds, especially, you know, we have got quite a significant overseas population, be it from the Philippines or from India. So it is at the back of our minds, although still not commonly seen in the local population because there's a BCG immunization that is standard in
Dr. Pal, that's a very good point that you made about tuberculosis being rampant in India.
We have to put it at front of our mind, not at back of our mind. It is so common to see microscopic hematuria and cause being tuberculosis. Although it is very difficult to exactly prove, all tests will remain negative, and only on empirical basis at times we have to start, I have to start a anti-cox treatment. And then when we see the weight gain and symptomatic relief as well as microscopic hematuria disappearing, then retrospectively it gets confirmed by therapeutic trial that the patient had a tubercular lesion somewhere.
Right.
What has been your experience, Shivam? Or
yes, in the initial evaluation of hematuria, yes, GU tuberculosis could be one of the causes in our country. But what we are talking about is the follow-up of these patients of carcinoma bladder, where these urine cytology and biomarkers are very important. So definitely, yes, now in urinary tuberculosis, as you said, in the initial evaluation, we are using the gene expert test also for urinary tuberculosis. So that is going to pick up many of these patients. So I think we need to see how to actually confirm the diagnosis of genital urinary tuberculosis, which is so rampant in our country. Another question about, I think it may be the last question to Nikhil, Dr. Nikhil, and we are quite often doing nowadays en bloc resections of bladder tumor. if it is less than 3 centimeter papillary tumor. And we find it quite impressive in the sense that we can remove the whole tumor en bloc with the muscle tissue. And even we have done a study in which we found that 90% of these tissues have muscle in them. And secondly, most importantly, I feel that it doesn't violate the oncological principle, which we often use in most of the other tumors, be it RCC, be it any testicular tumor, anywhere. We would not like to cut the tissue, tumor tissue, which may have a chance give rise to recurrence and more progression of the disease. So what do you think? What about the en bloc resection in future?
I think so. This is going to be obviously down to experience. I don't think a resident will get a Collins knife and start chopping a tumor out, but I think it's a good oncological principle. I still remember, I'd gone for a meeting to Leicester, and one of my colleagues mentioned, in which other tumor would you ever cut it up and use an EVIC and spread it all around the bladder? So oncologically, it makes more sense. The only challenge sometimes is getting the specimen out, which I've found. You might need to use you don't want to use a mocellator, but you have to use forceps and pull it all out and break it up sometimes. But I think en-bloc resection is a very, very good oncological technique. Jeremy from Hong Kong has presented a lot of data on en-bloc resection. And I think this will probably be the standard of care once more kit develops, especially to remove the tumor, because cutting it out is okay, but getting it out en bloc for the pathologist is more crucial.
I think it's
a very, very quick question.
Not a problem, because it's usually a papillary tumor, less than 3 centimeter tumor, easily comes into the ilex evacuator. We haven't found any problem in evacuating these papillary soft tumors. Even if it is 3 centimeter, it comes in the ilex evacuator most of the time. If it is larger, we have done even 5, 6 centimeter, 7 centimeter tumor, then usually we cut into 2 pieces or 3 pieces, that's all. And then it can come into the ilex evacuator. So I think the removal is probably not as difficult as you're thinking. So,
can I give you a practical tip? What I did was use a 26 French nephroscope in a female patient.
Yeah.
And through that nephroscope, our laparoscopic Caesar can go very easily through its working channel. And with the laparoscopic Caesar, you can very easily take out that cut at en bloc.
Right.
That's a very good tip, actually.
Yeah, a 26 French nephroscope, little bit dilatation of female urethra, past the nephroscope and this laparoscopic Caesar, and with that there is even coagulation also you can do.
Exactly.
Man puts his scope everywhere.
Yeah. Actually, this was presented about 6, 7 years ago in UCCon also. So where they have showed that even males also, they have passed a smaller caliber nephroscope with a smaller caliber scissor. They have just cut the stalk of the bladder tumor and done the en bloc resection. But nowadays with laser and with we are doing with Collins knife and laser, it's so easy to do it. So there's no need to put a nephroscope and just remove that with scissors. So I think
a very quick question to Dr. Nikhil. What do you think is the status of gene therapy in CA bladder? Where are we at the moment?
I think lots happening, sir, with adenovirus transfections. Obviously, sort of quietened down a little bit, but it was very popular, a concept of sort of adenovirus-based gene therapy to trigger cytokine responses intrathecally. But I think with the advent of genetic pooling of tissue, such as the tag analysis, when you do the biopsy and individualizing care, may be the way forward with gene therapy delivery, especially with T1G3 disease. So I think this is a broad area to develop more.
Thank you very much.
Right.
Thank you very much.
That those genomic biomarkers can help us to individualize the treatment of a person. Maybe so how aggressive we should go in any patient. Yes. If there is any comment from any of the faculty before winding up the session.
No, thank you for the opportunity.
Thank you.
Very, very nice to participate again and see you all, of course.
Wonderful interaction, and we really enjoyed it thoroughly, and our residents must have been benefited a lot. So thank you, Dr. Nikhil. Thank you, Dr. Tiang. Thank you, Dr. Saxena. And thank you, Dr. Pal, for joining the session. Thank you.
Thank you very much.
Thank you very much. And very good evening.
Bye-bye.
Bye-bye.
Bye-bye.